Yes, and thank you very much. We have, pardon me, and thank you very much that we also have translation for those who have difficulty with hearing. So thank you very much for joining us. So with this, let me please introduce my colleague, Dr. Sharon, who's going to give us the overarching presentation on the changing communicable disease scenario, NCD scenario.
Thank you. I can have the presentation. My name is Sharon Kapambwe, as I have been introduced, coming from the WHO Africa region. I am the WHO Technical Officer, Cancer Control, working in the Department of NCDs. Next slide. So as we are here, we are all aware of the increasing burden of NCDs among people living with HIV. The global burden generally is rising very rapidly, and we have premature mortality of young people dying from NCDs. And we know that about 95% of these deaths are occurring in low to middle income countries like Africa. And we know that among people living with HIV is that because now we have life-saving antiretroviral therapy, they're living longer, and when they live longer, like the rest of the population, their risk for NCD is also increasing. But we know that in addition to this risk, which is found in the general populations, effects of HIV, along with the adverse effects of ART, also increases the risks. The common NCDs that we see among people living with HIV are cardiovascular diseases, cervical cancer, diabetes, and depression. A study that was done this is a systematic review and meta-analysis done in 21 countries in Africa, showed that the same 4 NCDs I mentioned are ranking high. So we have hypertension. The first one that coming is depression, which is coming with a prevalence of 30.4 in those 21 countries that were reviewed. And then we also have hypertension. We have diabetes. You see cervical cancer at 1.5, but remember that the other diseases are both male and female, and cervical cancer is basically only affecting the female. So that's quite a high incidence rate as well. So in terms of burden, we're very sure that that is what is happening. The next thing that we see that we're talking about is when we look at the burden of NCDs, these comorbidities that we're having, including HIV and TB, is that of course when you have an NCD like cancer, we have HIV, you're also at risk of getting the 4 NCDs I've talked about, including even things like oral health. These have a negative impact on your life. Your quality of life is affected. It also increases the cost of care, because remember that you're already getting treated, somebody is already getting treated who's living with HIV for HIV, and then they acquire NCDs, they also have to be treated for that. And we know that TB remains a leading cause of death among people living with HIV. Diabetes and TB are the major causes of death over time. We've also seen. I'm going to ask you to change the slide. Sorry, the slides are behind me.
Can you please push the slide to the one next slide? Next slide.
Yes. Okay. Sorry about that. So when we look, knowing that TB remains the leading cause of death among people living with HIV, and people who have TB are also at a higher risk of getting diabetes, and those with diabetes can also get TB much more easily, and this is a major cause of death over time. We shouldn't forget about mental disorders that occur together with substance abuse, or which are also part of the comorbidities that are existing. So someone is going to live long, they're also going to They can end up with HIV if it's not properly but we must remember we can end up with AIDS itself as well if not properly controlled. But we should look into the co-infection of TB, and now we look into the issue of the comorbidity with NCDs as well. So this increases the burden of the medication somebody has to be on as well. So these are the interrelations that are really happening between HIV and TB. The next slide, please. Yes. So when we know we have defined what the burden is, what is happening when people have comorbidities, we really must. What are we talking about? And I just took one definition. There could be many other definitions that actually are there, but this is one core definition that I thought we could work with this morning. The reorganization. The key word there, reorganization, management of health services, so that people get the care that they need, when they need it, in ways that are user-friendly. So we're basically talking about achieving the desired results and providing value for money. So when we're thinking about integration, we are thinking about people-centered services as one of the key things. It's about a person. I'm the person who can come in with the various NCDs. Next slide, please. So on this slide, when we look at integration and what is currently happening, where are the people, where are the various tests that are going on, we find that current situation in most of the places, we have HIV services on one end. For example, we have cervical cancer screening on another end. So these are running as parallel services. So a woman gets treated or gets her care in the HIV clinic, then she goes to the cervical cancer screening clinic. If she's lucky, if it's well-oriented, she can do it on the same day, or you find that they're having it on different days. Then you find that we have TB services. So the TB services could be, and then you also have their hypertension services. Those could be linked. So you have intermediate, some kind of coordinated services. That's the second stage, where you can be referred to the hypertension and the TB services. The other one, you're going independently from one clinic to the other. And then finally, what we want is to have these integrated at primary healthcare level, where NCDs, HIV, TB, including mental health services, are all coming under one. Remember, I said integration is giving people the services that are user-friendly, but also ensuring that these services are people-centered. So what do we benefit when we look at integration in that case? It means that we are going to have a reduction in loss to follow-up. We're not going to tell you to come back, to tell the person who's living with HIV or getting care to come back so many times for different diseases. And that also reduces the morbidity and mortality, thereby increasing the life expectancy of that person. Better compliance. If you're going to tell me today, come for cervical cancer, tomorrow, you come back 2 weeks later and come and get your hypertension medicine, that means that the chances of me being compliant and being seen by different people becomes a little more complicated. It's also that we're strengthening the health system. What we have to remember, if we're putting services in for cervical cancer, for hypertension, for diabetes, for HIV, they're all going to strengthening of our health services, and thereby we are making efficient use of our resources. The next slide. So when we look at integration of these prevention and control, so we're having these healthcare services where person-centered detection and treatment. So a person can be able to be detected, and they're all coming in the end. We're looking at how these person-centered services are looking. Community-based, so that we can be able to pick some of these at the level of the community, at the level of the school, at the level of the workplace. There can be detection that can be done. There's health promotive services that can be done there. Finally, when we look at a whole population, what legislation is there in that country, what regulations are there, what information is there. So we're looking at also having policies and legislation for different things. You know that some of the NCDs, there's a lot of legislation that has to go on. And WHO has got the various, if you look to your right or is it your left, you see the various products that we have in NCDs. Elimination of cervical cancer, you have the Cervical Cancer Initiative. We have the integration, rehabilitation in health services. We are promoting, we have a global breast cancer initiative. We have ending childhood cancer queries, oral health. We have cancer services for children as well. We have promotion of cardiovascular health as well. Next slide. Some of the guidances that are there, and I'm not going to go through all of them, we have integration of mental health into HIV and TB and sexual reproductive health. That are already a lot of those guidances that are given by WHO. We have the PEN, WHO Essential Packet for NCDs interventions that can be done. We have the MHGAP, which is the Mental Health Global Action Plan. And just to make them a bit more visual, and there are more, so I just made a selection. My slides are behind again. Another one. Next slide, I should be pointing. Maybe I should. So this is a visual aspect of some of the various guidance documents, frameworks that WHO has produced to be able to help countries. You have, even for management of cervical cancer, you have for mental health, the integration. So this gives you a visual. In terms of monitoring, I'm not going to go into much details. We have the comprehensive monitoring and essential communicable disease interventions at primary healthcare settings, which will help with monitoring cardiovascular diseases. That's the next slide, please. Cardiovascular diseases, diabetes, asthma, and some cancers, breast, cervix, and childhood cancers, and other general cancers. So you see that even in terms of monitoring, we have these facility-based monitoring guidance. Next slide. I think we'll go through these quite quickly. We are running out of time. So some of the barriers that you see, knowledge gaps, practice, limited operation, evidence, and success stories at country levels. We want to see that. And even policy guidance at country levels as well is something that we should look at. And making sure there are always these concerns about, are we going to maintain the quality? What are we doing? And just to know that those are things that we should concern, ensuring there's domestic funding, there's external funding for that. Next slide, we should be going to almost the last slide. So those are the enablers that we're talking about. These diseases are occurring, next slide, yes, enablers. So these diseases are occurring, I'm the same person who's having, I can be the same person having HIV, having cervical cancer, having hypertension, having diabetes. Treat me as this one person who's coming in and avoiding fragmentation. Remember, when we are integrating NCDs, we are also increasing us attaining sustainable development goals and universal health coverage in the end. Last slide. Okay, can I go to the next one? The last slide. So what are we thinking on as a way forward? We need to tell our existing national health policies towards integration at all costs. At country level, regional level, global level, we have to establish high-level multi-sectoral coordination mechanism, especially at the country level, even sub-national level as well, that are looking at this integration in a much more coordinated way. We must begin to foster collaboration and partnerships. We shouldn't be dealing with the silos that we're dealing in. This is money for HIV, this is money for TB, this is only for hepatitis. But let us make sure that we're dealing. Remember, the key word is person centers, and we should build our health force that can multitask most of these things. At the end of the day, like I said, when we address the gaps that are going on as far as integration is concerned, we are really looking at the value that we bring to the patient's care in our facilities, and that should be the end. Thank you.
Very much. I think you're bringing up some really important questions about person-centeredness, but how are we going to deliver this? And I think that's some of the questions that hopefully we'll get through in some of this conversation. Can a single healthcare worker do it all? Or can a single clinic do all of these things? Maybe aspirational, but I think they're going to be different models that work in different settings. And to be honest, we may need to not let the enemy be the perfect be the enemy of the good. If we can get some of this done in a way that reduces a person's movement, but has good healthcare workers who can address quality services, I think that's going to be our aspiration as we move forward. You know this better than we do, and I think we need to start documenting some of those practices. So now it's really a pleasure to introduce Dr. Christopher Passy, who's going to be presenting on non-communicable diseases and HIV, unpacking some of the clinical interactions of the existing pandemics with emerging epidemic of metabolic and cardiovascular disease. So I think here we're going to get a clinical presentation perhaps. And if you had questions from the first presentation, we'll make this the next 10 minutes or so, 15 minutes, and then we'll have another presentation, and then we'll have, if we're quick, we'll have enough time for some Q&A. Over to you. And please remember to say next slide. And here you go, you can take this.
That's why I stood up. All right, I think I will stand here so that I can have a look at the slides and therefore be able to conduct the orchestra. I'm going to be, I've got 10 minutes to unpack this. It's a very clinical presentation for those clinicians amongst us, to just have a look at some of the interactions that are there. We know that with that, as my colleague has just presented, with access to effective HIV care, basically HIV has become a manageable chronic disease. And as such, people are living longer, and there is the vicissitudes of then developing from our treatment and obviously lifestyles, developing hyperlipidemia, altered glucose metabolism, insulin resistance, bone density abnormalities, fat redistribution, and mitochondrial toxicity, which causes a number of the other adverse events. Next slide. This slide, I think, just concentrate on the right side, the lower one, where we are just showing that the number of estimated deaths from AIDS is becoming less, and therefore the burden of disease of metabolic disease is going to be long. Next slide. What is important is to note that there has been now a convergence in terms of guidelines for treatment in the Americas, Europe, WHO, where dolutegravir has become a common component of all those, together with tenofovir, either as the disoproxil or as the alafenamide. So there has been now a combination in terms of, a meeting of minds in the way that we treat HIV. Next slide. In this pooled analysis of about 8 randomized clinical trials, Gilead sponsored, what one can see is that the mean weight change with the different classes of ARVs, we can see that the integrase transfer inhibitors have got a much higher change in weight compared to the other medicines. And then if we go to our right side, you can see that when we are looking at your NRTIs, the tenofovir alafenamide is actually a higher weight gain compared to the others. Zidovudine, we are rarely using it. It's got very little changes in terms of weight gain. Next slide. Pharmacogenetics, which is very important probably for us here in Africa. That's when in that same random pooled analysis, you can see that the black female tends to get higher weight gain compared, next will be the black males and then the non-black. So that issue is critical, that in Africa we have to start looking at that issue of pharmacogenetics. You know, I know we are given the medicines and then we use them, but we have to try and look and start looking at our own patients and seeing what's happening. Next slide. In this multi-center, multinational Europe, Australia study where with 29,000 participants, a median follow-up of 6 years, we can see that the risk of cardiovascular events increased in the first 24 months of integrase exposure compared to no integrase exposure. But what is surprising is that after 2 years, the risk seems to come down in terms of the risk of cardiovascular events. That's myocardial infarction, stroke, and any invasive CV procedures. Next slide. In this cohort, which was almost 99% of it were Black population, we can see that these are estimated 10-year risks of cardiovascular disease and diabetes. And we can see that a combination where you have dolutegravir and TAF at a higher mean increase at 144 weeks of increased cardiovascular risk and also diabetes risk, with efavirenz and tenofovir disoproxil having the least. What is important is that probably this informs the decision to make the first choice in terms of treatment, unless somebody has got a problem with bone or problem with renal, that maybe one should be avoiding the combination between DTG and TAF and probably go DTG and TDF because we know that the DTG is quite a strong backbone in terms of HIV treatment. Next slide. So initiating or switching to an integrase-containing regimen increases the risk of new onset diabetes with or hyperglycemia in 6 months. So O'Halloran and colleagues were looking at a big database of persons who had started taking an integrase inhibitor and found that within the first 6 months, new onset of diabetes. But these are sort of database-based, studies rather than follow-up studies. And an increase in the BMI was associated with the initiating a DTG with a TAF in the same regimen. Next slide. What is interesting, though, is that in this Swiss cohort study, where they looked at these participants who were initiated on an integrase inhibitor, they didn't find any difference between the observed. So the different arguments were that probably it's when you are switching rather than when you are starting. And when you are switching, it's when you are switching probably from a TDF to a TAF-based regimen where this might happen. So the issue was that probably the jury is still out in terms of what actually is happening there. Next slide. So the key take-home points from those studies are that the risk factors for weight gain include Black race, particularly probably female, low pre-treatment BMI, starting an integrase inhibitor together with a TAF. And weight gain has been associated with diabetes mellitus and hyperglycemia. However, we note that the RESPOND and the advanced study were seeing different things from what the Swiss cohort study was noting. Next slide. The mechanism of cardiometabolic consequences are not quite clear. The difference in weight change between TDF and TAF appears to stem from probably a weight suppressive effect of TDF. There may be a class effect as far as the integrase inhibitor has impact on weight and glycemic control. Next slide. Hypothesized mechanism of integrase weight gain includes possible effect on adipocyte differentiation thermogenesis, estrogen-mediated pathways, maybe that's why it happens more in females, the effect on adiponectin or hormones that regulate glucose and lipid metabolism, suppression of melanocortin stimulating systems that increase appetite, and the effect of magnesium chelation, which reduces the insulin sensitivity. So some of these are all hypothesized mechanisms, but we still need to be able to try and find out what actually causes these issues. Next slide. So for these patients, you know, for individuals switching to TAF and integrase inhibitor from an old regimen, we need to counsel our patients that they may be weight gain. We need to monitor weight and metabolic parameters. We should actually make sure that when we are checking for diabetes, we shouldn't be using HbA1c as a method of monitoring these patients, because there is a disconnect between HbA1c and actually the fasting blood sugar. So for clinicians in the room, you should be, whether you are monitoring or you want to diagnose, it's better to use the fasting blood glucose rather than the HbA1c. Next slide. We know the issue of tenofovir as an antiretroviral causing problems of nephrotoxicity, being more in those with advanced age, low body weight at the start, and who we have noticed that in this country, because of a nurse-driven and clinic-driven arts program, you know, initiation starts early before anybody knows what the starting creatinine is. And now we are not doing CD4 counts. This is a viral load-driven program. And therefore, these are some of these things that we need to tweak around and be able to understand. And renal toxicity is usually related to proximal renal tubule mitochondrial toxicity. Next slide. Next slide. This needs no introduction. The issue of tenofovir disoproxyl fumarate and bone health. In this meta-analysis where they were looking at TDF being used for either PrEP treatment or HBV, we noticed that there seems to be reduced bone mineral density, although with PrEP, there was no increased fractures. Quick slides going down. I think most of my, let's next slide. Next slide. This is the last slide that I just want to talk about, that we should always remember that HIV, AIDS, and lipid alteration already sometimes is existent even before treatment. So the low serum concentration of high density lipoprotein sometimes is already there and is a marker of chronic inflammatory activity. And therefore, when we are now exposing the patients to these medicines, it even compounds the effect. I think I will end on that slide, and thank you very much.
Thank you very much. I think it's a really nice juxtaposition from the big epidemiology. We know there's demographic shifts alone bringing NCDs into the forefront, but then for people living with HIV on different antiretroviral therapies, there can be exacerbation and increasing weight gain, increasing challenges with lipids, et cetera, related to the drugs themselves. And teasing that out is really important. And we know in some of the countries where this is a problem, they're actually starting obesity clinics, et cetera. I mean, removing the stigma, allowing people to stay on their therapy, addressing the weight issues. And I think there's so many new drugs coming that will be able to help also address some of the diabetes and overweight issues together in a single drug. So I don't want to say that it's over-medicalized, but I think in many ways we need antiretroviral therapy for somebody's livelihood, but we also want to be able to be assured that they can have access to the other medicines for their chronic diseases as they age, and to age in the most healthy way possible. So really good, really nice conversation. I think with this, we have one more presentation, and I don't think there's a session right after us, but we'll ask Professor Kwasi Thorpe if he can try to stay within his 10 minutes so that we can have a few Q&A. But over to Prof. Kwasi, who is online, who will be talking about integration of NCDs and HIV programmatic options. Over to you, Kwasi. So we're having technical difficulties. Can we find if he's online? He's online now? No? Yes? I know he's been online. He's okay. Do we see him up on our video? I think what would be best is if you pull up his slides, we'll run the slides. There you are, Professor. We can run the slides for you. I think that might save your bandwidth. If you could pull up the third set of slides, and each time you change your slide, just say next slide, and then we'll make sure that we're moving along. So over to you.
Thank you for this opportunity.
Can we we unmute him? Your slides are up in the room. We're on the title slide.
Hello? Hello?
Prof, we don't hear you in the room well, so if you pause, we can hear you very lightly. So let's see if we can try again. And see
Hello,
if we
can you hear me?
audio up a bit.
Hello, can you hear me?
So we know that they're working on putting you on the sound system as we speak. So why don't we take one question from the audience and until we have that IT issue solved. So if somebody has a question, why don't we take the close question here and ask to whom you'd like to pose your question. Very brief, please, because we know that we'll have Prof on in a moment.
All right. Thank you so much. My name is Venus Mushiniga from Zimbabwe. I just want to find out from WHO, are there any financing mechanisms that are being put in place for NCDs, or we are still looking at trying to integrate? Because I think for the Global Fund, there was an attempt, but there were challenges. And I also wanted to find out if there is any drive towards integrating data collection and tracking for NCDs, like in ICASA. How far is that initiative so that we have data for NCDs? Thank you.
I think for the first time, we actually did manage to get a lot of countries. WHO supported the development of their proposals for NCDs. I know Zimbabwe was one of them. Zambia, we must have gotten about 13 that actually put in NCDs in their HIV Global Fund proposals, including cervical cancer and mental health. So we did bring countries together, I think Ghana, and they came over to Zimbabwe for some days and we helped them to develop those, and those were approved by the Global Fund. So we should have countries already that have integrated their I think on Tuesday, we already had an example of Zambia, of how they have integrated using the funding that they have from Global Fund and PEPFAR, how they have integrated NCDs, mental health, inclusive, and under the NCDs, they have cervical cancer as well, where they're even going further as using the HPV testing, which is recommended by WHO. And NCDs now, from the Afro perspective and the global perspective as well, we have, okay, I will Okay, so we have also what is known as the PEN Plus. If you've heard of the PEN Plus, so we have the PEN Plus strategy, which is looking at severe NCDs, and that is looking more at district level. And the management of severe NCDs, there's funding that is going on, and countries are going to be benefiting from that as well. So that's working with the Hemsley Foundation together with the Global Cancer Initiatives for Breast and Cervical Cancer. We have more initiatives that are coming in. And I know that Zimbabwe is looking into integrated services for women coming in for breast and cervical cancer detection. So we have that is going on from the WHO perspective. Thank you.
All right, great. What there isn't a PEPFAR or a global fund for NCDs. It's really about integration and maximizing what you can do with some of the extra support. So, and country level financing coming from country allocations or country themselves taking on some of these issues. So I think we're good now with Professor. He's linked into the audio system, so we want to give him his time on the agenda. So over to you, Professor Twarpi.
Thank you very much for this opportunity, and then also thank you for the previous presenters.
If you start speaking, we can start now.
Yes, okay, so I'm starting. So I think my presentation, I'm going to look at a different
We
perspective.
still are not hearing you on the system. So we're figuring out a way to get you onto the system. I'm sorry.
Hello? Hello?
Is this working or not? All right. Okay, go ahead, Professor.
Hello, can you hear me now? Hello?
I think if we can't figure this out in the next minute, we're going to, because we only have about 5 minutes less, I think we may have to go back to questions and share Professor's presentation with you online.
All right, yeah.
Is it solved?
Hello?
Unfortunately, Professor, it doesn't seem to be working.
Okay.
I really am apologetic. We can't hear you in the room, even though we know you're on the computer. It's just not linking into the audio system. So what we're going to do is we're going to move to a few more questions, and we saw a lot of hands up. And what we'll make sure we do, Professor, is get your, if you can videotape this, we can make sure that it gets out to those who are at this session today or online. Thank you.
Okay, thank you.
So thank you so much, presenters, for the fruitful presentations. My question is targeted. Sorry, firstly, my name is Alvin Tengerere, and I'm from Zimbabwe. And so my question is targeted to Dr. Pasi. So you mentioned something about HbA1c in patients on integrase inhibitors, that we should not use it. We should not rely on it for confirming the diagnosis and also for monitoring of diabetes. I just want to know, why is it that we don't use HbA1c in this group? And among people living with HIV, is it only for those on integrase inhibitors, or maybe there's another subgroup where we can't use or rely on HbA1c for confirming the diagnosis and also monitoring?
Thank you for that question. It's not only on for patients on integrase inhibitors, but there is a general issue which I know it's very small print kind of thing, where persons living with HIV, particularly on ART, there are issues to do with HbA1c, using it as a reliable marker of hyperglycemia. It even gets worse when the sugars become higher. There are issues to do with increased MCV. As you know, HbA1c, we are relying on hemoglobin. So there's the issue of increase, and some of the patients may have low-grade hemolysis. So it can also affect the HbA1c as a sensitive marker. The lower sugars better, but as it becomes more and more, it becomes less and less reliable. Thank you.
Yeah, thank you. I very much enjoyed your presentation and the comment that followed from Dr. Doherty about the use of incretin mimetics, oral semaglutide, orforglipron, or other candidates that are in the pipeline. I think we are lacking clinical trials of people living with HIV using this drug, safety and efficacy. We are not looking probably at access to these products in case we need to roll them out more generally. There was this reprieve trial on the use of statins for people living with HIV. I wanted to ask you about your clinical view on this, and also from the programmatic aspects, because it was even discussed to put these statins, use this statin as soon as people are put on ART. So I wanted your feedback on that, please.
No, thank you very much. I think the chair did put it out that, are we going to be throwing everything? It's like even in the field of diabetes, where somebody, once you diagnose diabetes, put a statin, put aspirin, put this. So, yeah, I think it's one of those things that is interesting. And my thoughts are probably the same as yours in terms of how much medicines should we be loading these patients? Should we just be following them up? And what do we do? Because I do agree, atherogenicity has started before. You saw the HDL, even at the time of infection, is already low. And so you're losing your protection of HDL. So thank you very much.
Okay. Could just endorse, I think it's a very good area for clinical trial, because I do think that there, if you talk about stigma, I think there's been a lot of discussion after the advanced trial about weight and should people come off dolutegravir or TAF because they've gained weight. And most of the clients did not want to change. And I think it's then about managing the weight and how to best do that. Because for many ways it was very good for their HIV and viral suppression. And so you're going to have to manage all of these, and that's where this is, as people age, that's where, having a very good primary care doctor, clinic, internist who can manage these complications, I think it's going to be more and more important. And certainly we want to have people being able to access these drugs, which are now not accessible, I don't think, for low and middle income countries, and are being my senses are being prioritized for diabetes when they've been as good, if not better, for weight loss, which, is a chronic problem in the entire world. And so it's not just about getting out there and running, it's really about changing the way the food, gut interaction, brain interaction. So, yeah. So any other questions do we have out there?
I was just thinking, there's also the issue of implementation science for NCDs and HIV that we haven't been doing enough, particularly in our region. We really need to know what is going on in this space. And even as we start to think a lot of integration, we have to look into the area of implementation science. So people should take up that part of research so that we know exactly how best some of these issues can be dealt with. Thank you.
I think we had a number of hands up. Do we have a roving mic? Okay, the person with that mic in the hand gets to go question.
Okay, thank you. And I'll be quick. Ibrahim Tajuddin from Nigeria. To the presentation on integration. The first concern that I have is looking at the support that we are getting now at the country level. The support is more or less prescriptive. You have allocation for HIV. For example, if you want to use Global Fund as an example, you have allocation for HIV, TB, malaria, and the country is left with option of saying, okay, do you want to have a standalone RSSH, which is a vehicle to integration. And when you propose certain amounts for RSSH, you get feedback that no, you can't do more than XYZ%. So how do we build integration? That's the question. Then at the country level, for the country that you've supported as WHO to implement, to develop policy, yes, beyond policy development, without strong will from everybody, integration is just going to be a lip service. And then when it comes to management of weight gain, to the prof, the concern I have is now at the country level, we've over-medicalized intervention, especially when it comes to HIV/AIDS. The supportive interventions, which will enable the patient on ARV as well as some of the other drugs, are not there. And you look at the economic capacity of this individual, they hit junks, there's no balanced diet. And at what point are we now linking health promotion with this treatment and then the management of the patient for us to have, better quality service as well as health outcome?
Thank you. That was 3 questions, so thank you very much. We are 5 minutes over, so this will be our last question. We'll have a dual answer, and then we'll make sure you can get on to your next session or come up and talk to the speakers if you have more questions. So over to you.
So quickly, just to say that you are very right about having certain limitation depending on the funders or the donors for that particular. And this is where in my last slide I talked about high-level coordination. And for Global Fund, you have your CCM, your country coordinating mechanism, and the country is the one that proposes what should be done. And if a country itself is resolved through their policies and their intervention by the various factors that we need to make sure that this is an area of priority, that does happen. And there are countries that have been able to go beyond what has been prescribed because the country has put up a strong case. What we will do as WHO is really to help you to come up with this strong case, looking at what the burden is in your country, what are you bringing, the information that you have, and put up a strong proposal that then can be presented to funders like Global Fund. But the first place is having the policies, the guidance, the regulations that are needed at country level, and a high level coordination mechanism at country level goes beyond you just meeting, but being known at cabinet level, being known at ministerial level, which is more of a cabinet, and you're parliamentarian. So it's a